Hello to everyone. Good morning or good evening, depending on where you are. Apparently, this is a webinar which includes several hundred people. My name is Rolando Cimaz, and I am head of the Rheumatology unit at the Meyer Children's Hospital in Florence, as well as Professor of Pediatrics in the University of Florence. This webinar is entitled Avoiding Misdiagnosis, Clinical Manifestation of Inherited Metabolic Disorders for Rheumatologists and General Pediatricians. A few housekeeping notes before starting. Please do not take any screenshots. The webinar record will be available online as soon as it is over. Please do not reproduce slides, content, or images. And this presentation will last about 20 minutes. It will be followed by a question and answer. You should submit your questions anytime during the presentation via the panel chat questions. And the question can be submitted only via text, not verbally. At the end of the presentation, I will try to answer all the questions, or at least as many as possible. So the topic of the presentation is differential diagnosis of juvenile idiopathic arthritis, in particular the differential diagnosis with inherited diseases and especially metabolic diseases. For those who are not in the pediatric rheumatology field, JIA, as we call it, is an exclusion diagnosis. So there are many diseases that can mimic JIA, especially at the beginning, and a diagnostic workup is fundamental. The mucopolysaccharidosis are one of the great mimic of juvenile idiopathic arthritis, and this will be also part of this presentation. There are some instances where the diagnosis is straightforward. I have put in this slide a few photos of typical presentations or typical complications, especially of juvenile idiopathic arthritis. From the left top, clockwise, you see some deformity. This is a valgus deformity in oligoarticular JIA. And then you see x-rays with very bad hip involvement, x-rays with cervical spine involvement and fusion. Lower right, you see synechia from uveitis, growth disturbances, and bilateral hip replacement. So of all of these, there is no doubt that the diagnosis is juvenile idiopathic arthritis. And actually, if you do a slit lamp examination during the diagnostic workup and you see synechia, or you just see inflammatory eye disease in the anterior chamber, that is already the diagnosis. I will start the presentation with a clinical case of a patient with nothing particular in the past medical history, who presented with myopia, diagnosed when he was 4, and then the following clinical history was complicated by bilateral retinal detachment at 12 and 15 years of age in the right and left eye, respectively. He was quite tall, and interestingly enough, he had pain and stiffness of the joints at the knees, but hypermobility in the elbows. This is not what we see in juvenile idiopathic arthritis. The patient came to rheumatology, and it was clear from the beginning that the diagnosis had to be something else. In this case, there is a little quiz, but the answer of this quiz is easy for us, which is not Blau syndrome, which is early onset sarcoidosis. It is not Cogan syndrome, which is vasculitis with deafness. it is not mucolipidosis type 3, but it is Stickler syndrome. Stickler syndrome is an inherited genetic disorder characterized by defects in the collagen type 2, in the precursor of the alpha chain of the collagen type 2. And it has genetic heterogeneity, transmitted mostly autosomal dominant. It is a rare disease with no gender predilection and interfamilial variability. Stickler syndrome is a genetic disease that can mimic inflammatory diseases because of the pain and because of the stiffness in the joints, but it has extra-articular manifestations, especially those related to the ear, nose, and throat, with depression, nasal bridge, anteversion of the nostril, cleft palate, and Pierre-Robin sequence. And it has very prominent ophthalmologic findings, such as myopia, early onset cataract, vitreoretinal degeneration, chronic uveitis, and last but not least, hearing loss, which can be neurosensorial or transmissive. So with arthropathy, this is one of the diseases to suspect, especially when there are ocular and hearing abnormalities and when there is joint laxity on top of the stiffness, such as in the patient that I just presented. Characteristically, the metabolic and the genetic disorders do not have laboratory abnormalities, such as we see frequently in inflammatory arthropathies. Another case is an Italian boy that we have followed over time, born full term by vaginal delivery with normal pregnancy and negative family history, normal psychomotor development. This boy at 7 months of age had a hip ultrasound, which was called abnormal, put on a double diaper, and started to walk very late, at 2.5 years. At that time, he was complaining of pain in the left hip area. The story went on and on without a diagnosis until when he was 11, the pain was so severe that he had walking difficulties, articular function limitation, which was worsening, was admitted and had a severe limitation of the joints, not only in the lower limbs, but also in the elbows, and the flexum contracture of the hips, which are stiff and painful, also of the knees. This is a photo of the lower limbs of this child when he came to our attention. This is a maximum flexion that he could reach and the maximum extension that he could reach, both at the hips and at the knees. So he was wheelchair bound. In this case, the quiz that I made was quite easy for us. This is not a story of juvenile idiopathic arthritis, so A, B, and C are not recommended, but X-rays were performed and showed several abnormalities without going into detail on the bone abnormalities. A good radiologist was enough to make the diagnosis of progressive pseudo-rheumatoid dysplasia, which is called also PPRD. And this is again a bone dysplasia, a genetic disorder caused by mutation in the WISP3 gene. And for those who are interested, there are reviews, and this one is the largest on a cohort of more than 60 affected individuals. A few other examples of bone dysplasia or bone and joint disorders that can mimic JIA and that are on a genetic basis. This is called camptodactyly arthropathy coxa-vara pericarditis syndrome, abbreviated as CACP. And when pericarditis is present, diagnosis is quite easy. If you have pericarditis and camptodactyly, often not all the features are present, and in this case, diagnosis can be challenging. And you can see in the photo the coxa-vara, the camptodactyly, and the arthropathy. This disease is caused by mutation or in a protein which is called lubricin, which is expressed in chondrocyte and synoviocyte, and important for lubrification. So with this and other bone dysplasia that I don't have time to present, family history is very important, but you have seen in our cases, as is present in many other occasions, that it can be negative. Exam are not so important in terms of blood investigation. X-rays are very important, so I would do a spine X-ray, which very often is a clue to the diagnosis, but needs to be reviewed by experienced radiologist who has an interest in pediatrics and in bone and joints. Sometimes you need some more specific instrumental investigations of radiological in the radiological field, such as CT scan and MRI. But this is just when you have a specific doubt of an inflammatory arthropathy. And synovial biopsies now are very rarely done, only in very doubtful cases. They used to be done more frequently in the past when we did not have the genetic tests that are now available. So, as I said, the most important is a review film by an expert pediatric bone radiology. And these are just examples of bone dysplasia, some that I just showed you, and different, you see how different they are from juvenile idiopathic arthritis, which is has to be joint swelling by definition, which is frequently absent, more often absent in the bone dysplasia, functional limitation, joint stiffness, and inflammatory symptoms such as a limp in the morning, and very little of other bone abnormalities at X-ray, especially at the beginning. Frequently, there are abnormalities in the laboratory tests. This is another child that we have followed in the past, who started having difficulty writing and diminished hand function when he went to school. So around 6 years of age, he presented to his physician with stiffness in the MCP and PIP joints. Then symptoms worsened. He had flexion contracture of the hands, progressive involvement of all joints, which are functionally limited, but not swollen, not tender. Laboratory was negative. At that time, we called juvenile chronic arthritis, which was the working diagnosis because we did not have any better explanation. However, there was no response at all to non-steroidal anti-inflammatory drugs, and a particular feature appeared, which was bilateral carpal tunnel syndrome. In this case, the attention was raised to a differential diagnosis, which was mucopolysaccharidosis. Mucopolysaccharidosis can have a joint and skeletal disease caused by storage of the substrate, which are mucopolysaccharide or glycosaminoglycan, in synovium, in bone, and in periarticular tissues. This can give stiffness and joint contractures very frequently, joint pain, over time skeletal deformity, and loss of mobility and functional independence. The clinical manifestation of these skeletal abnormalities are gibbous, spinal deformity, abnormal X-rays on pelvis, thorax, hips, and then knock knees, but it is especially the joint stiffness, as you can see in the photo of the hands of this patient, that characterizes disorders. MPS, which is mucopolysaccharidosis, are divided in several types. It is especially the type 1 and type 6 that can mimic at the onset an inflammatory arthropathy. And when we think of MPS 1 especially, it can be very severe, such as Hurler syndrome, which can be fatal in the first month of life, and you can have more attenuated phenotypes, such as shy syndrome, which is MPS 1S, meaning shy. In this slide, you can see an example of the less severe MPS I, so the shy phenotype of this patient who was diagnosed very late, more than 40 years of age, despite the fact that the first symptoms, which were joint stiffness, appeared in the pediatric age, so in the first decade of life, and then had neurological, pulmonary, gastrointestinal, and cardiac complications, all of which led to the correct diagnosis only after decades. So there are some cases in which there is dysmorphism in the face, short stature, large abdomen, and many other systemic manifestations. However, in the attenuated forms, skeletal manifestation can be prominent, and outside the bone and joint, there might be just minor hints, such as rhinitis or limited endurance, which may not be enough to suspect the correct diagnosis. This is an example of a lady who was perfectly normal in first year of life, and then in adolescent, and as a young adult began to have her complication, and ultimately became blind and wheelchair bound. We collected a few of these patients, and I want to show you this slide mainly for two reasons. First, that the family history was negative in most cases, and second, because the hint to the correct diagnosis, which was quite late in some cases, you can see at 54, 53, 33, 41. But what was very helpful was the presence of carpal tunnel syndrome, which in pediatric age has a very important role, because you have to suspect a storage disorder of different kinds. And the onset of symptoms in all of these cases was stiffness, mostly in the fingers and the hand, in the first 10 years of life, sometimes even earlier. There may be other disease manifestations in MPS I, even in the attenuated forms, but sometimes they are minor, such as fatigue, short stature, thick skin, excess hair, and in the less severe types, such as the shy, there is no primary CNS involvement, unlike the Hurler disease, which has a severe neurological involvement. The differential diagnosis of patients who ultimately were found to have shy syndrome is wide, and these were the misdiagnoses. In other words, the patients who had shy syndrome at the beginning did not have the right diagnosis, but mainly they were called as having inflammatory arthritis, juvenile, idiopathic, or juvenile arthritis. It is the same if it was into the pediatric age, or if they were adults or young adults, rheumatoid arthritis. And then there were other diagnoses that were suspected by the treating physician. So the message is mainly that if you have joint contractures without inflammation, clinical and laboratory, so with no joint swelling, that may indicate in the differential diagnosis inherited disorder, such as, for example, the bone dysplasia that I showed you at the beginning, or the storage disorder that I just mentioned to you, such as MPS. The differential diagnosis sometimes is very easy. If you find joint swelling, such as in this knee, with morning stiffness, maybe with uveitis, then there is no test, additional test to do, but you have a clinical diagnosis of joint swelling of more than 6 weeks duration, with no other plausible explanation. The MPS are many, as I said, and mainly it's the type shy, so MPS 1S and MPS 6, which is mahotolami, that can mimic juvenile idiopathic arthritis, while in Hunter, Sanfilippo, Morchio, Sly, and so on, diagnosis is sometimes easier because there is a more generalized and systemic involvement even from the very first months of age. This is MPS 6, for example, in which also there are bone and joint abnormalities, and you can see again that flexion contracture of the fingers give a typical claw hand deformity and are very helpful for the diagnosis. And again, the last point of this slide is probably the most useful because it is rare, carpal tunnel syndrome in pediatrics, while a joint stiffness can be present in many other manifestations. And just like MPS 1, MPS 6 is also underdiagnosed because the presenting symptoms may mimic other diseases and because these are rare disorders, so you need to think about it and to know the clinical manifestation. So the conclusion of the talk is that joint contracture without inflammation can be a hallmark of inherited disorder, bone dysplasia, storage disorder. Clinic carpal tunnel is very suspicious. If you suspect a storage disorder such as MPS, you can order the test. The screening test is urinary GAG, glycosaminoglycans. Some patients may present to a pediatric rheumatologist with a bone dysplasia or with a metabolic disorder because the presenting symptoms can be osteoarticular, and at the onset, extracellular manifestation may be either absent or subtle or overlooked, and full-blown picture may occur even years late. So this was the last slide of the presentation, and now I am happy to answer the questions that have been posed by the panel. So I repeat the question because I see them on my computer. The first question is, what is the gold standard for juvenile idiopathic arthritis diagnosis? This is a good question, but unfortunately, there is no gold standard since juvenile idiopathic arthritis is a diagnosis of exclusion, as I said. So the clinical judgment of the treating physician would be the gold standard. That depends on the experience of the person. You would need, of course, a long-standing duration. By definition, it's more than 6 weeks, but usually, if not treated, it can last even more than 9, 10, 12, or even months. In fact, the old classification, European classification of juvenile chronic arthritis needed 12 weeks of persistence of arthritis, meaning swelling in a joint seen by a physician, and exclusion of other diseases that can mimic, just like the diseases that I mentioned to you, plus a number of other disorders, especially infectious disorder, reactive arthritis, hematologic disorders, and so on. So there is no laboratory test that can give you this diagnosis, but just clinical observation. Now there is a second question which is related to it. What are the main signs that can differentiate GIA from metabolic disorders? Many, I already mentioned them during my talk, mainly the absence of inflammation. So the metabolic disorders typically have normal inflammatory parameters and absence of joint swelling, that is presence of palpable synovial fluid. Sometimes there is the joint seems swollen, but it is periarticular or it is bony overgrowth. To have a diagnosis of an inflammatory arthropathy, you would need joint effusion. And also, this is usually accompanied by inflammatory signs that I mentioned, which is mainly the joint stiffness or morning limp if it is lower limbs. The third question, why is it important to make an early diagnosis of mucopolysaccharidosis? It is important indeed because now there are effective treatments. There is the enzyme replacement therapy for not for all of them, but for 1, 6, and others. There is a possibility of infusing the enzyme. There is a transplant. They are working on other type of gene therapies, but for the time being, already the enzyme replacement therapy is available, and it has been shown that if you treat this patient early enough, you can prevent later complications and improve the quality of life. How is diagnosis confirmed if I have a suspicion of MPS? You have to do the first test of suspicion, which is a urinary GAG, and then you can do the enzyme and the gene, but these are done in specialized labs only, while the GAG is more diffuse and you can probably do it in your own hospital. Then the enzyme is done only in metabolic laboratories. What is the number of specialized centers for the treatment of these disorders in Italy? So if the treatment for this disorder means arthritis, juvenile idiopathic arthritis, we are many pediatric rheumatologists in the country, mainly the big cities, but every region of Italy practically has at least one center who is dealing with this. If it is meant to be metabolic disorder and mucopolysaccharidosis in particular, there are less. The exact number I cannot tell, but probably in a country like Italy, there are at least 3 or 4 in northern Italy, 2 or 3 in central Italy, and 2 or 3 in the southern, in the south of the country. So I would imagine a total of 10 to 15 metabolic, pediatric metabolic centers which deal with metabolic diseases, including MPS. The genetics is a little bit more diffuse because genetic disorders are present practically in all pediatric units. So this was the last question from the audience, which I thank very much for your attention, and I hope that this talk was useful for you. Thank you.